So our final talk will be AIREVAC transport of Ebola-infected military personnel with burns or trauma, preliminary proposal, and it will be by MAJ Raymundo Racela from the Institute of Surgical Research.
Good afternoon. Thank you and for SAGES for giving me the opportunity to present today. I have no disclosures. An unprecedented Ebola virus outbreak in West Africa began in 2014. WHO statistics to March 2015 with near 25,000 cases, over 10,000 deaths, case fatality rate approximately 60% for hospitalized patients. By the end of 2014, the Ebola virus had infected 822 healthcare workers with 488 deaths. The US had 4 cases. The Ebola virus is spread through direct contact with blood or body fluids. No evidence of airborne transmission. 1 virion is sufficient to cause infection. The incubation period is 2 to 21 days. Humans not infectious until symptomatic. The severely ill have massive amounts of diarrhea, up to 12 to 15 liters per day. Unexplained bleeding reported in approximately 18% of cases. PCR can detect Ebola as early as 3 days after inoculation. Biofire film array assay with results in 1 hour, presently on CDC emergency use authorization. No proven treatment available at this time. Supportive care with rehydration and treatment of specific symptoms. In September 2014, President Obama tasked the US military to provide equipment and resources to battle the Ebola epidemic. 4,000 US troops deployed to West Africa to construct treatment facilities and testing labs for at least 1 year. Contingency plans proposed for possible air evacuation of burn or trauma patient by the burn flight team. A comprehensive literature review had no articles on an Ebola patient that needed definitive surgery due to burns or trauma. AIREVAC is via the US Air Force asset with a photograph transport isolation system. It's modular, portable, disposable liner, fully sealed with self-contained air filtration system, can fit in a C-130 and C-17 aircraft, and can accommodate 3 litter or 4 ambulatory patients. The burn flight team is composed of 5 personnel who work daily in the only burn center in the Department of Defense. A general surgeon with additional training in burn and surgical critical care serves as the team leader. Also, a critical care registered nurse and a licensed vocational nurse, both with significant experience working in the burn ICU. A respiratory care is provided in flight by a certified respiratory therapist with extensive experience using multiple ventilators. A medical non-commissioned officer serves as the operations NCO for each mission. All personnel complete the US Air Force Critical Care Air Transport Team course. All personnel entering the designated orange area or coming within 6 feet of the patient would be in full personal protective equipment. During OIF, OEF, the burn flight team conducted 100 missions. 374 patients were AIREVAC'd. From the time of notification for a patient pickup to the patient arriving at a US facility is 72 hours. Surgical guidelines have come from the American College of Surgeons and the US Army Medical Command via some CDC recommendations. They use checklists in the preoperative, operative, and postoperative phases. Emphasis is placed on protection of healthcare workers via training and donning and doffing of PPE with a trained observer, covering all skin and using impermeable barrier material. Some intraoperative recommendations include no OR in positive pressure room, prevent aerosolization, reduce number of IVs and sharps, electrocautery over scalpel for incisions, substitute endoscopic surgery for open surgery when possible, and strict management of material waste. We must take each patient on a case-by-case basis, but initially, you try to characterize the risk of exposure to Ebola as either none, some, or high, which determines the risk of infection and thus the risk to the surgical team. This proposed burn trauma flow sheet begins on the left, months prior on the institutional level, with review of guidelines, coordination with the many elements required to take care of an Ebola patient, education about the virus, then training with PPE and mock scenarios, and our burn flight team has already gone through this. Patient with a burn or trauma with high exposure risk or a positive test, consider non-operative or minimally invasive approach in order to decrease personnel involved and minimize fluid exposure. If the patient with severe active disease, patient would likely not tolerate any type of operation and could be considered as expectant. Any decision to operate should weigh all risks and benefits, specifically the risk of death from the current severity of their infection, risk of death from their surgical disease, and risk of exposure to the OR team against the likelihood of potential benefit of emergency surgery. With burns, advantages of silver dressings and cerium nitrate are number 1, to minimize provider contact with the patient, and number 2, enable prolonged non-surgical care. Disadvantages are neither penetrates eschar and problems with resistance. Extensive full-thickness burns would normally be treated with either number 1, sulfamylon cream alternating with Silvadin cream, and definitively excision and grafting. With trauma, if OR is needed, consider least invasive, such as laparoscopy, endoscopy, interventional radiology. If cleared, definitive surgery if still needed. In summary, we need to understand the Ebola virus, need to plan ahead, protect personnel, minimize their exposure, and real-live PPE training. Consider the least invasive approaches to surgery until patient cleared either by lab or recovered from the Ebola virus. The proposed concepts are guidelines and in no way should hinder good clinical judgment tailored for the individual patient. Thank you.